Perfect. So thank you for this kind presentation. And my name is Ole Graumann. I am a radiologist, and I'm doing this speak together with my patient representative, Karen Vilmand. She'll not be joining the speak up here, so she'll be participating in the panel discussion later on. So first of all, I'm a radiologist, and I have got absolutely no idea on how to, involve the artificial intelligence. So this will be a clinical perspective from my point also. I believe that what's hot right now is mammography. So I'll use breast and mammography as a case for you the next 20 minutes. So first of all, as you know, cancers in the breast cancers are seen very often. It's like 1 out of 8, maybe 10 women who get a cancer. So that is a major concern. So that's why we in Denmark do screening. So if you are above 55 and below 69, you will be offered a screening, a breast mammography every 2nd year. So in this region we're in right now, we are 1.22 million people, which gives us 60,000 mammography annually. So if we have that many images, we have a problem because the numbers of radiologists has not increased at all. It's actually very stable. So for each patient, we have 4 images. And those 4 images takes one radiologist 1 minute to look at. That's all they have. The problem is that the radiologists are actually in the clinical work busy doing clinical work, which means all the screening are being done outside the normal work. So that's a huge burden on the radiologist. And I'm pretty sure that you look into the newspapers, actually seen that there are actually so much lack of doctors that they're actually buying artificial intelligence to help us look at these images. So that's what my talk is going to be about. So this is one of the breast radiologists looking at an image. So it's an awesome, great workload on us. With lack of radiologists. But then there's the next concern. That's actually the equipment we get, the images we get. It has so much information, has so much precision, and the quality is so much better. So we find the cancers even before we used to do. So what do we need? Of course, we need artificial intelligence to help us. So my question now is, why not just buy the system? Today in Copenhagen, they're buying the system and just putting it in. And today I got another call from Aarhus saying they want to buy it too. So why shouldn't we just buy it and implement it? So there are 2 companies out there who's actually done quite a work on cancer findings and screening. The top one, ScreenPoint, that's a company from the Netherlands. And they have tested their algorithm on a huge population. The lower one is Lunit. That's from Korea. And they have tested the algorithm on very many different breasts from around the world. So the question is, why not just buy them and implement it in the daily clinical work? That's a no-brainer, right? But then this article came out last year, actually this year, only a few months ago. And I just want to highlight, I can't see anything up here. I just want to highlight here. So current evidence on the use of AI system in breast cancer screening is of insufficient quality and quantity for implementation in clinical practice. This is a systematic review, sorry. So they concluded that in retrospective test accuracy studies of 94% of AI systems are less accurate than original radiologists, and all less and all were less accurate than original consensus of 2 radiologists. I think this is quite interesting. So we're saying buy it, but actually we have got no none prospective studies out there. These 2 algorithms are both CE and FDA approved. And we're just saying in Denmark, this is a good country, buy it and just implement it without even knowing if this is it working. So I'm going to end this talk in roughly around 12 minutes with a SWOT analysis. So just to highlight you in this. So what we did in our research group is, oops, we need to go down here. So the region of southern Denmark, they had a couple of million for research within AI. So we applied and we got the highest amount. So we got almost 5 million Danish kroners to do research. And we were asked to do 2 things. 1, to look into the IT infrastructure of AI and how to build new AI research. And 2, to do research within breast screening and to, very important, to implement it, to start it in the clinical work. And we have 4 years and we spent 1.5 years till now. So that's where we have our magic. That's a good name. Nobody's okay. So magic. That's magic. Okay. So just a few words about magic, because I think it's pretty cool setup. So this is the steering group. So we have Per Busk. He's head of the hospital in Esbjerg. He's the head of the steering group. Then that's myself. I'm the PI. Then we have the smart guy, that's Benjamin. He's the one who knows a lot about AI. He's also a radiologist. And then we have Camilla. She's the organizing girl at SIMT. And then this down here, that's probably also the most important thing. That's all head of the departments, the radiology departments in all of region of southern Denmark. And maybe you're laughing, but everybody who does research knows that you need the right people here. And they're all keen on this. So the project group, that's again myself and Benjamin, but now it's Mohammed, and I have to thank Mohammed for this presentation because he did it for me. So this is Mohammed. He is a PhD student doing all these work and studies here. Again, Camilla. And on the lower, you will see our breast mammography. You will see Mads Nielsen, and I noticed that there was somebody from Copenhagen also. Mads Nielsen is actually from Copenhagen, and he's very interesting because he did one of the very first studies within AI on imaging, finding cancer. So he's very interesting. And we have Oke, he's sitting up there, also in the group. So it's a large group, but there's more. And I'm keen to just spend a little bit time on this because it's complicated, but also very important that everybody is mentioned also. So we have our chief for all the images, that's Paul Erik Gunnar, and then we have Henrik Jørgensen, that's the smart guy who knows all the technician. And then on the bottom, you see that it's very important that you have young doctors coming in. So that's Johanne doing research for us, but also a data science study assistant called Sarah, who's helping us. And then, of course, we have research collaboration with both Lunit. We have research collaboration with ScreenPoint, Open. I'm not going to go into Open. And then, of course, Philips. Okay, that's probably going to mention in my SWOT analysis at the end. Okay, so what's the whole idea of this? So the whole idea is to make this is the world's largest multi-center study which will be performed. And it will be across all the 4 sites in region of southern Denmark, which means Odense, Vejle, Esbjerg, and Åbenrå. And maybe to you it sounds like a small study, but this is the world's largest study within this subject anyway. So there's a lot of data from everybody and a lot of other people. And these are the numbers that I would like you to remember. So it's 262,000 images. What's important and what we think is probably what will give us jackpot and maybe come into the best journals ever, hopefully, is that it's a homogeneous group. who lives within the same region, we have 2 follow-up periods. And that's important that you have 2, because in between those 2 years, we have interval cancers, which means breast cancers that actually comes in between those 2 periods. And those numbers are very interesting to us, because maybe the AI could detect the cancers without the human eye could detect the cancers. Okay, and the very last one is that we just need to do retrospective study of 2 independent algorithms. Okay, so how is it working today? Today, each woman are being seen by 2 doctors. If there's no cancer seen by the 2 doctors, if they agree about the screening, that's the last one, they'll just continue, they'll just have a button pressing normal and they'll just continue screening. If there's disagreement between the 2 of the doctors, it'll automatically go to the 3rd doctor who has a lot of experience. In this region, we have 2 of those, very old ones. If all of them agrees that there is a problem, the patient gets a recall and gets into the hospital and gets examining. So this is a lot of time, very time consuming. So what we have thought together with the company was that the AI is built in. So the AI in this, and this is a retrospective study, so we have all the images. So this is just a thought example of how the future could work. And we think this is what we will do in our next prospective study. So the AI will look at the images first and say, okay, this is a high-risk patient. So they'll be looked at 2 persons. And those numbers are low. And if it's a low risk, it'll only be seen by 1 doctor, which means that we can have more patients coming through the system. And then it will be the same flow with triage and 3rd reading and recall. So this is my SWOT analysis. So for the strength, we think that we have high data quality in the Danish healthcare system, especially when it comes to screening, because they have the same names and numbers they will use when they report the images. Then we have the strength of validation and comparing 2 AI solutions. We'll have all of our region. And then there's the weakness, which I think is very interesting. So it's extremely time consuming, this. We have legal permits, data collection, etc. Processing comprehensive data set require a lot of resources. And then, and please notice this one. One of the companies did not allow us to compare in one study the 2 companies to each other. So it's in the contract. You cannot take the numbers that you get here and compare it 1-to-1 in one publication. Strange, but we're okay to do 1 study and then another study, 2 publications, that's okay. But the company is actually saying you cannot do this. I think that's an ethical dilemma. Maybe we can discuss this later, how much power the company actually has. The opportunity is, of course, with the doctors, with the lack of radiologists, we'll resolve that. We'll have the uniform screening can lead to maybe greater and equally health in health system, improved diagnostics and streamlining of workflow, and also the IT infrastructure could benefit definitely future projects within AI. The threats are also something that's on my concern these days when Copenhagen are buying the system and Aarhus also are buying the system. So we're very much dependent on these companies. We've got absolutely no clue on what the finance expenses is going to be when buying these systems. And what about the GDPR and ethical issues within this? And in the end is the desired effect achieved, which means patient, less cancers, and cancers are being found sooner. Okay, that's like 15 minutes, a little bit faster.